in the other slide set, I talked about an overview of what heart failure was, but what I want to do is a little bit more detail now on treatment as well as the updated guidelines on heart failure. So this is the 2016 American College of Cardiology, American Heart Association, Heart Failure Society Association. This is a most recent update. And so I had shown you on some other slides the evidence table here, okay, because remember class 1 is strong evidence, moderate, weak, moderate to no benefit, harm, strong, as well as your level A, the randomized controlled trials, whether it's high quality, moderate quality evidence, etc. And it just goes down from there. Okay, so let's move down here. Now this is stage C. So this is where the changes are. So pharmacological treatment for stage C heart failure with the reduced ejection fraction recommendations. So on the last slide set, we talked about ACEs, we talked about ARBs, aldosterone inhibitors. There's a new drug, ARNIs, which we're going to talk about here. Okay, so recommendations for renin, angiotensin, system inhibition with an ACE inhibitor, ARB, or ARNI. So this is what's recommended, an ACE, an ARB, or the ARNI. The clinical strategy of the renin-angiotensin system with ACE inhibitors or an ARNI with evidence-based beta blockers and aldosterone antagonists in selected patients is recommended. In patients with chronic heart failure, reserved ejection fraction, to reduce mortality and morbidity. So what they have found, if you use ACE inhibitors, it can reduce mortality, and randomized controlled trials clearly established that with mild, moderate, or severe symptoms, with or without coronary artery disease. I want you guys to read through this, but I want to show you that these are the latest recommendations that maybe you can just print out just a couple of these pages. A lot of these are more references and things like that. So angiotensin receptors blockers also help with the that you can use alone, and it says much lower incidence of cough and angioedema, which we know that, than ACE inhibitors do. So if you have a reaction to the ACE inhibitor, you should give an ARB, but give it with caution if they have low systemic blood pressure, renal insufficiency, or elevated serum potassium. An ARNI is an ARB. It's combined with an inhibitor of neprilysin. It's an enzyme that degrades natriuretic peptides. So we think about the BNP, bradykinin, adrenomedulin, and other vasoactive peptides. So remember, our body's just an amazing thing that has so many different hormones and chemical reactions taking place. It's just really just amazes me every time I see all these new hormones and stuff. So the newest one, which just came out not too long ago, is valsartan sacubitril with enalapril. So you take this with enalapril in symptomatic patients with heart failure, reserved ejection fraction. Tolerate an adequate dose of either an ACE or an ARB. So say that's going to put somebody on an ACE. It's like lisinopril. You always start low and go slow. So you'll start at 10 milligrams on your lisinopril. So again, it just depends. But remember, start low and go slow. And you monitor their blood pressures. Just remember one thing that's important: if these people have lower blood pressures and they're asymptomatic, you want to keep them that way. If they're symptomatic, obviously with severe dizziness or even dizziness at all, you may want to consider going down on the medication regimen. But remember why they're on the medication regimen in the first place. So if they're asymptomatic, you want to keep them on that. So let's go down. Another recommendation: the use of ACE inhibitors is beneficial for patients with prior or current symptoms to reduce morbidity and mortality. Also, the use of ARBs to reduce mortality and morbidity is recommended in patients with prior or current symptoms who are intolerant to ACE because of cough or angioedema. So if they can't tolerate the ACE, you go to the ARBs. In patients with chronic symptomatic heart failure, this is the NYHA class 2 or 3 who tolerate an ACE or ARB, replacement by an ARNI is recommended to further reduce morbidity or mortality. So whether they're Cardiologists are doing this. I'm not really sure how many are actually taking them off that and putting them on this ARNI. I'm not really sure, but I want you to know that that's out there. As far as the ARNIs, you don't need to know that for exam purposes, but you just need to know that ACEs are the mainstay, or an ARB, and these are out there also as recommendations. An ARNI should not be administered with an ACE inhibitor or within 36 hours of the last dose of an ACE inhibitor. So if you're switching them over, you want to wait 36 hours before you're putting them on there. These are oral neprilysin inhibitors used in combination can lead to angioedema, and concomitant use is contraindicated, should be avoided. And then an ARNI should not be administered to patients with a history of angioedema. So here's one, omapratolat. It's a neprilysin inhibitor, as well as an ACE inhibitor and aminopeptidase P inhibitor. So they're associated with the higher frequency of angioedema than that seen with enalapril of patients with that. So just don't give it. They have a threefold increase in angioedema as compared to even the ACE inhibitor. So we know that they even have a higher rate of that. Okay, so here's another medication. It's called ivabradine. And ivabradine is a new agent that selectively inhibits the cyanoatrial node. It helps reduce the heart rate. So this is another one. I don't know how often it's used. Maybe you've seen it in the hospital before. But I just want you to know that. You don't need to know this for testing purposes, but I wanted you to know the latest guidelines that are out there. And obviously we see now ACEs, if not tolerated, they go to the ARBs, or they can put them on the ANRIs, but they have to take them off the ACE inhibitors. And that is it.